Today's Fern educational session involves critical long COVID symptoms, brain fog and headache, fatigue and weakness, and chronic inflammations. What are their pathologies, how to clinically diagnose these patients, and how to optimize patient outcomes. My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine at the U of I in Chicago, and I'm Medical Director of the PA Studies Program at Dominican University in River Forest, Illinois. I am Fern President and Board Chair. I have no financial conflicts. You can find this information on our fern.org website and our YouTube channel at fern.org. This is a screenshot of our playlist page. I encourage you to go there for more neurological emergencies information. This is my contact information QR. So our first educational objective is to discuss COVID-19 and the acute infection seen and the pathophysiologies observed during the acute COVID-19 pandemic. We will discuss the COVID-19 virus, pathophysiological mechanisms. What were the COVID-19 injury mechanisms observed during the acute pandemic? With COVID-19, it was observed that there is diminished arterial blood flow and lung dysfunction with resultant tissue hypoxia. Mitochondrial dysfunction was observed and microthrombosis in the arterioles. CSF outflow disruption was seen. Increased CSF glutamate levels were observed. Gut dysbiosis was seen, and there was direct cell death in virtually every organ tissue observed. Let's discuss some of the CNS mechanisms seen with the acute COVID infection during the pandemic. The COVID-19 virus was seen to use the ACE2 receptor for access to the cells in the body, especially in neurological tissues. It entered the brain through the nasal olfactory epithelium and through CNS capillary endothelial lining cells. This caused the potential for cerebral edema prior to diffuse organ system loss of homeostasis. Another CNS mechanism was direct infection that caused hypoxic injury, given that it's a respiratory pathogen using the ACE2 receptor, and causing immune injury through the SIRS accelerated and excessive inflammatory response. It also caused toxic encephalopathy through direct infection and viral encephalitis and acute cerebral vascular disease. Additional CNS mechanisms include neuromyopathy, encephalitis, Guillain-Barré syndrome, seizures, status epilepticus, transverse myelitis, and flaccid myelitis. These symptoms are seen with many viruses, not just the coronavirus, but there is a direct neurotropism of these viruses that suggest that neurocells and neurotissues are at greatest risk. The affinity of the COVID virus for nerve tissues explains why there are so many observed CNS complications with acute and chronic COVID-19 infection. Another proposed and observed mechanism for COVID-19 complications is cytokine storm. With COVID-19 infection, both IL-6 and IL-10 were observed to be elevated, and the ratio of IL-6 to IL-10 seemed to predict some complications during cytokine storm with COVID-19 infection. There's also a sympathetic storm seen with COVID-19. This causes a dysautonomia. There's direct autonomic pathway neuronal injury, immune-mediated injury, sympathetic nervous system activation, inhibition of the parasympathetic system. There are sympathetic and cytokine storms, therefore, that activate the renin-angiotensin system. With COVID-19 acute infection and sympathetic storm, we see both cardiopulmonary complications and neurological sequelae that directly result, likely, from these abnormal cytokine and sympathetic storms. Our second educational objective is to examine acute COVID-19 neurological illness and injury seen early and during the pandemic. Early on, from observational case series from Wuhan, China, several hundred patients demonstrated that 40% or more had severe neurological complications in 3 different categories. CNS categories including dizziness, headache, altered mental status, stroke, ataxia, and seizure. Peripheral abnormalities such as taste, smell, vision abnormalities, and nerve pain, and skeletal muscle injury as a neuromuscular complication. Regarding COVID-19 headache, a Medline search of 41,000 patients who were described during the pandemic demonstrates that headache was seen in up to 12% of patients in 2 phases: acute headache in the viral infection phase, and headache later associated with hypoxia and with the ongoing cytokine storm. More information regarding acute COVID-19 headache symptoms. It was recorded in up to 1/3 of hospital COVID-19 patients, the headache being described as bitemporal, frontal, or periorbital. It often was new with sudden or gradual onset, rated moderate to severe, as a throbbing or pressure with a poor analgesic response. There was an observed high relapse rate for headache during the acute infection, and the observed peripheral trigeminal nerve ending problems related to pro-inflammatory hypoxia and/or cytokine storm. Regarding the COVID-19 CNS complications, myalgia and headaches are common. Direct viral invasion of all neurological tissues was seen, causing myopathy, polyneuropathy, rhabdomyolysis, meningitis, and encephalitis. It was frequently observed that anosmia and ageusia, the loss of smell and taste, were seen in many COVID-19 patients. Also observed were post-viral autoimmune processes, encephalomyelitis, and Guillain-Barré syndrome. Now, what were some of the neurological sequelae seen in patients with COVID-19 during the acute pandemic? One study of 43 UK patients demonstrated encephalopathies, inflammatory CNS syndromes, stroke, Guillain-Barré syndrome, and brachioplexopathy. Another study during the acute COVID-19 infection demonstrated altered mental status and coma. In this case report, a 64-year-old Chinese patient with no medical history, a fever up to 38.5, cough, myalgias, developed lethargy and unresponsiveness 13 days later. In this patient, dissociated speech, ankylosing, Babinski and Chaddock signs, and meningismus were observed. The CT and LP were negative, and the patient did recover and was discharged 17 days later. Another patient case report demonstrated an acute COVID-19 meningitis bout. This 24-year-old patient, 9 days into an episode with fever, headache, and fatigue, became unresponsive, had an episode of emesis, and was found lying on the floor. There was transient generalized tonic-clonic seizures observed, and CSF COVID-19 was detected. The MRI was positive in the lateral ventricle, temporal lobe, hippocampus, all suggesting meningitis. 2 case reports demonstrated the complication of meningoencephalitis in the acute COVID-19 phase. A 64-year-old woman with no psych history was admitted to the psych ward and then had tonic-clonic seizures consistent with focal status epilepticus. The MRI was normal, but the LP showed meningoencephalitis. The patient was treated with acyclovir and improved over 4 days. A second case report involved a 67-year-old woman who was COVID positive for 17 days. She one day had an intense wake-up headache, was confused, had bathroom syncope. She was found to have a left-sided stroke. The MR was okay. She had CSF pleocytosis. She was treated with acyclovir antibiotics and was discharged after 4 days. Another complication of acute COVID-19 infection was orbital cellulitis. A 12-year-old Egyptian male was seen with 3 days of orbital swelling. The patient had orbital cellulitis, surgery, and antibiotics to effect a cure. A 15-year-old male had 3 days of orbital swelling, was treated with ceftriaxone and vancomycin. The CT showed pansinusitis, orbital cellulitis, and an epidural abscess. This patient required surgery and had a complicated course. The acute COVID-19 infection was also seen to cause cerebralitis. The case report involved a 63-year-old male with altered mental status and ataxia. The patient had had COVID-19 5 days prior. The neurological exam demonstrated cerebellar symptoms, a broad-based gait with truncal ataxia. Imaging revealed white matter degeneration and edema of the cerebellar hemispheres. The symptoms in these patients completely resolved with COVID-19 treatment with corticosteroids and intravenous remdesivir. The MRI in this case showed bilateral cerebellar white matter signal abnormalities in this patient with COVID-19 cerebralitis. The acute COVID-19 infection was also seen to cause transverse myelitis. 1.2% of all COVID-19 neurological complications involve transverse myelitis. The baseline incidence for this acute disease is much less at 0.003%. So this represents a 400-fold increase in the rate of transverse myelitis as a result of COVID-19 infection. 2 case reports include a 56-year-old with leg weakness and urinary retention, and a 43-year-old with fever, sudden onset of both lower limb numbness, weakness, inability to sit, and urinary symptoms. An example of the inflammation seen with COVID-19 and transverse myelitis is observed in this T2 image from the spine, showing abnormal cord signaling extending from the cervical C2 down to the thoracic T11 vertebral level, seen with the faint red arrows. Also seen with acute COVID-19 infection were CNS thrombosis cases. A representative case report here is a 64-year-old male who had a wake-up stroke, left hemiparesis. No TPA was provided. 16 days prior, the patient had had fever, myalgias, and COVID-19 infection. The patient had tachycardia, hypertension, hypoxic respiratory failure, and required endotracheal intubation. The CT showed hypoattenuation and loss of gray-white matter differentiation. The CTA showed an internal carotid artery high-grade stenosis, but otherwise no IC occlusion. A repeat CT at 24 hours demonstrated cerebral edema, mass effect, and a right MCA and ACA territory involvement. COVID-19 acutely was also seen to cause CNS venous thrombosis. A case report here is of a 59-year-old male, 4 days of frontotemporal headache, diabetes, hypertension, persistent severe headache, and fever. The patient had CT superior sagittal, transverse sigmoid sinus, and IJ vein densities suggesting of thrombosis. The CTV was otherwise negative. 4 days later, when the patient developed stroke symptoms of unilateral weakness, slurred speech, and expressive aphasia, The CTV was reread as showing sigmoid and transverse sinus defects. Low molecular weight heparin was provided, and the patient's NIH stroke scale went from 10 to 4 over 24 hours, and the patient was successfully discharged home. Regarding acute COVID-19, thrombosis, and the sequelae of this complication, one review suggested that hypercoagulability was the cause of this complication, and that it caused acute cerebral vascular disease, acute ischemic stroke, acute disseminated myelitis, as well as Guillain-Barré syndrome. A true viral encephalitis was actually more rarely seen than the encephalopathies associated with the complications of the COVID-19 virus acute infection. Regarding COVID-19 and thrombosis, the thrombosis was associated with the initiation and amplification of the coagulation cascade in small arterioles throughout the body. This was seen as a result of the disrupted endothelial barrier and clots in arterioles in all body tissues. Regarding acute COVID-19 mechanisms seen in pediatric patients, several are proposed and have been observed, including endothelial injury, direct viral effects, post-infectious inflammation, and para-infectious inflammation and symptoms seen with long COVID. Our conclusions regarding COVID-19 pathology during the acute infection and the COVID-19 pandemic. COVID-19 acutely causes a viral infection with secondary infections that result. There is both direct neuron and CNS tissue toxicity from this coronavirus. There is endothelial damage in the arterioles in every tissue of the body. SIRS and inflammatory effects also are seen as a result of the acute COVID-19 infection. These inflammatory processes cause complications not directly caused by the virus itself, and the thrombosis seen in the arterioles in the tissues and organs throughout the body have been associated with the complications seen with acute COVID-19 infection. In summary, COVID-19 acutely was observed to cause significant neurological complications and adverse effects in every age group. Thank you for participating in this Fern educational session. You can find this video and others on our YouTube channel at Fern.org. Have a good day.